Okay, so why do we talk about ARDS and trauma patients? Well, there's been a couple studies out there, actually quite a few of them. This one is a prospective study out of Seattle. It was almost 1,300 trauma patients. The outcomes measured here were mortality and cost, and they found that there was no real increase in mortality. That's different than from a lot of other studies. What they did find was the cost increased by 30% when these trauma patients came in and ended up with ARDS, and also increased the ICU stay. There's multiple other studies showing that trauma patients do worse and have higher mortality rates with ARDS, so that's kind of why we're discussing this. So the objectives here, we'll discuss the history, we'll define ARDS and acute lung injury, come up with some incidents and outcomes, we'll talk about causes, and then the current and future treatment options kind of all together. So ARDS was initially reported in 1967 by Ashbaugh and colleagues. It was reported in Lancet. Then later on in 1992, the actual definition was more standardized. The American European Consensus Conference developed a standardized definition of this, and over the past 4 decades, our understanding has improved with this. So the definitions defined there were acute onset of severe hypoxemia, diffuse bilateral pulmonary infiltrates, absence of left atrial hypertension, and then a changed ratio of PaO2 to FiO2. Now this ratio, as you see there, is acute lung injury if that ratio is less than 300, and if it gets to be worse and it's less than 200, then it's actually defined as ARDS as long as you have those other 3 components of the definition. The problem with these definitions, the diagnosis is based on clinical and radiologic information. And radiographic findings can be challenging. It can be difficult to actually standardize this. I mean, the definition states diffuse bilateral pulmonary infiltrates, and it's based on people who read these things. And the interpretation can vary widely. There's actually a study done in '99. Rubin and colleagues asked 21 experts, so-called experts, to evaluate chest radiographs from critically ill patients that were hypoxic. And they used these definitions, and they found that only 43% of the time they actually agreed. So you can see that the definitions is not exact, and it can make diagnosing ARDS actually a little difficult, which then will affect the incidence that's been reported through the literature. Other limitations include the measurement of the pulmonary artery wedge pressure. Many of these studies have shown that depending on who does the measurement, the value will actually change. And as we know now, most of our patients don't even have Swan-Ganz catheters, so it's hard to actually get that measurement. So how accurate are these definitions? Well, this was looked up in 2004. Esteban and colleagues compared clinical findings with autopsies. Now, this was a retrospective study. They were all very severe cases because they all actually died because they all had autopsies. But they found that the clinical diagnosis, the sensitivity and specificity, was only 75% and 84%. So you can see that diagnosing this isn't exact as well, which makes defining the incidence even harder. This is largely uncertain. First estimates from the National Heart, Lung, and Blood Institute back in '76 defined it with 150 cases per year, which roughly comes out to be 75 cases per 100,000 people. And since then, the ranges have been anywhere from 1.5 to 78 per 100,000 people get this. But what we're seeing over time is actually the incidence has been declining, and we see it here. We haven't even seen a case since I've been here. Multiple studies that I looked up, more recent ones from '06 and '07, actually show that a decrease of at least 50%. And what these have attributed this to is lung protective ventilation strategies early on before they actually get ARDS, and conservative transfusion practices have attributed to this decrease in incidence. So how do these patients actually do if they have ARDS? Well, there's a wide range of mortality rates through the literature as well. Anywhere from 23 to 71% mortality rates have been documented in the literature. Several factors contribute to this, and that's how they actually define this in the literature, the ARDS and acute lung injury, and then what has changed over time. And you notice a lot of these studies, if you read them, it's over multiple years when the treatment changes have occurred because of ARDS Net. So the mortality rates have been lower. Early reports showed rates between the 64 and 70%, and more recently it's more like around the 30 to 40% range is what is more reliable at this point. These patients, what do they actually die from? Well, this is a severe form of hypoxemia, but death from respiratory cause is actually very rare. It's actually 20% or less are actually from primary respiratory problems. Most deaths are caused by sepsis or multi-organ dysfunction syndrome. And the causes that we attribute to causing ARDS and acute lung injury, there's two broad categories. There's the direct lung injury versus indirect lung injury. The direct lung injury, as I got here, pneumonia, aspiration, toxic inhalation, near drowning, and lung contusions. We see that all throughout trauma. The indirect lung injury, this is also we see this in sepsis, burn patients, patients with pancreatitis, eclampsia, and then massive blood transfusions all can contribute to indirect lung injury causing ARDS. So now that we've defined and kind of gone over the incidence and what causes this, so how do we treat this? There's three broad ways that we treat this. The primary ways are supportive care, pharmacological treatments, and then ventilator support. With supportive care, we need to identify and treat the causes. So if it's a septic cause, we need to get to the source, drain any source of sepsis, or cut it out if that's the issue. Avoid secondary lung injury, so do our lung protective ventilation, which we'll talk about in a little while, to avoid barotrauma and other problems. Avoid over-resuscitation and unnecessary blood products that can add to acute lung injury or transfusion-related lung injury. And we need to maintain adequate oxygen delivery during patients when they have ARDS. We need to make sure that they still get adequate oxygen to the tissues. And if that means with this oxygen content and oxygen delivery equation, which I'm sure we've all seen, just make sure that the patients are adequately oxygenated. And nutritional support's important as well. Make sure these patients are fed from very early on in their clinical course so that we're not getting behind the 8 ball in that sense. So what are the pharmacological treatments that have been looked at and used to treat ARDS? The two main ones in the literature is inhaled nitric oxide and anti-inflammatory therapy. So inhaled nitric oxide, this is a smooth muscle relaxant. It affects blood flow in the lungs. It lessens the inflammation components of ARDS. The clinical benefits have not been proven in the literature. It's not real clear whether or not it's a benefit or not. Its best use is for short-term rescue therapy, and rebound pulmonary hypertension makes weaning difficult in these patients that are treated with this. There's actually a study from '06, a study from 46 different U.S. centers. They looked at 385 total ARDS patients. So you can tell that towards the later years, it's harder to actually get high numbers because the incidence is actually dropping. They randomly assigned patients to either 5 parts per million in inhaled nitric oxide versus just a placebo gas. And what they found was that there was no effect on the outcomes measured, which was cost, survival, or ICU stay. So their overall conclusion was that it wasn't all that helpful in these patients and not to use this on a routine basis. Plus, it's more expensive now, I guess, because there's only one company that you have to get this from. Anti-inflammatory therapy has been tried. There's been many drugs, ibuprofen, ketoconazole. The most common one that we see in the literature is the high-dose and low-dose steroids. Most have actually not been shown to be help. Corticosteroids, up to about 2004, there was 4 good studies, or total studies, that showed some benefit in unresolved ARDS greater than 7 days. They were all small-numbered studies. 3 of them were actually uncontrolled, and the outcomes showed low mortality rates, 20 to 24%. The only controlled trial was small. It did show that the mortality rate was 12% in the treated group versus 62%, but it was a very small trial. The more recent studies we'll go over briefly here. There's two of them. This one from New England Journal of Medicine was a recent multi-center randomized controlled trial. 180 different patients with ARDS greater than 7 days. It was double-blinded, given low-dose methylprednisolone or placebo, and their primary endpoint was 60-day mortality. And their results showed that the 60-day mortality was virtually unchanged, or no different, 28.6% versus 29.2% in the treated group. So they also showed that steroids were associated with a significant increase in mortality if started greater than 14 days. Now, the way that they actually weaned the steroids off was different than any of the other studies, and they may have weaned them too soon, causing rebound phenomena, which could have affected their mortality rates greater than 14 days. Their conclusions were, though, that the results don't support routine use of steroids for persistent ARDS, and actually starting them after 14 days into the course could actually worsen your outcome. The second recent paper that we've actually talked about both of these in Journal Club, this one was from Chest in 2007. It was a study looking at low-dose prolonged steroids in early ARDS, not late or greater than 7 days. It was randomized, double-blinded. It was out of Memphis, or 5 different hospitals there. They had a total of 91 patients. They treated these patients with the study if they were less than 72 hours of ARDS. The primary endpoint was using a reduction in lung injury score. And what they actually found, their results, was that the treated group actually had a 1-point reduction in almost 70% of the cases, where only 35% in the non-treated group. So they actually did find a benefit. They found lower C-reactive protein levels and a reduction in duration on the vent as well. So their conclusions were that the steroids induced downregulation of systemic inflammation. It was associated with significant improvement in pulmonary dysfunction and reduced duration on the vent. So the take-home here on steroids is that the high-dose steroids don't seem to be a benefit, but there could be a role for low-dose steroids if started early enough. But the routine use, I still don't highly recommend every ARDS patient getting routine low-dose steroids. There's also some recent data showing there may be some benefits in 2 different patient populations, and that's ARDS caused by fat emboli or those caused by P. carinii. Ventilator support is the third way to treat these patients. Lower tidal volumes, which we'll go over the ARDS Net paper very briefly. Adequate PEEP, safe levels of oxygen, avoid barotrauma, adjust the ventilatory rate, and permissive hypercapnia are all ways that we treat these patients. So the ARDS Net protocol that was set up, it was a multi-center randomized trial of ARDS patients. It compared traditional ventilation techniques of 12 cc's per kilogram versus 6 cc's per kilogram, which the hypothesis was that the lower tidal volume would actually be beneficial. And the primary outcome was death in these cases. The secondary outcome was days without a ventilator. They actually had to stop the trial early. The enrollment ended up being 861 patients. The reason why they stopped is because they found a lower mortality rate, 31% versus 40%, which was significant. The numbers of days without ventilation also was different. It was statistically significant. It was 12 versus 10 in the treated group. So their conclusions were that in patients with acute lung injury and ARDS, mechanical ventilation with lower tidal volume than is traditionally used results in decreased mortality rates. But I think we all know this, but this is the historic reason that we've switched our ventilator modes. So has this actually been beneficial since the original study? Well, this study was in 2005. This shown to decrease hospital mortality. This was a respective study from UCSF. Compared 292 patients with 92 of the historical control patients. So they took almost 300 of their patients, compared it to 90 patients in the ARDS Net original study. And what they found was mortality rates decreased from 51 in the control group down to 32 in their group, which was very consistent with what the original paper showed. So even through the years, it actually has shown that it is beneficial. The precise mechanisms are not fully understood of why this actually is beneficial. Some of the studies show that excessive strain and shear stress may be the cause or maybe why it's beneficial. Shear stress amplifies lung inflammation, so the more you stretch out the alveoli, you can increase lung inflammation. You exacerbate the barrier disruption when you stretch this out with higher tidal volumes, and you can promote ongoing edema. So ventilator support, there's some innovative ventilator strategies that have been cited through the years. High frequency ventilation, inverse ratio ventilation, airway pressure release, prone positioning, surfactant, liquid ventilation, and then ECMO. So I looked up most of the literature on this, most of these ways, and we'll go over some of them. So high frequency oscillator ventilation, it's the most extreme form of low tidal volume. It was first used in neonates. It uses frequencies of about 5 to 10 hertz, and it just has a constant distending of the airway is the way this works. Studies are few. There's only 2 randomized studies. They were large enough, but they showed that there was no mortality improvement between the 2 groups. They just showed that the technique is safe, but whether or not it actually is beneficial, it doesn't decrease mortality rates. They did show some transient oxygenation improvement, but overall, they don't recommend just switching to this mode. Inverse ratio ventilation. This was designed to increase the inspiratory phase of ventilation with respect to expiratory time, or increase the IDE ratio. Standard is 1 to 2. In this technique, they use more 1 to 1. The evidence is controversial whether or not it's beneficial. The literature is very, it doesn't show that this is the way to go. There's a high discomfort level, so these patients most of the time have to be heavily sedated on the ventilator. Airway pressure release ventilation. This uses a continuous positive airway pressure at a very high level with a superimposed time cycle release phase to lower pressures, which theoretically optimizes your recruitment of your alveoli and allows for spontaneous breathing is another benefit of this type of APRV. There's a few large trials on this. Best is out of Baltimore Shock, and it's not really, it's more of a retrospective look, and it just looked at all their patients over time. And what they showed was that the incidence of multi-organ failure and mortality was actually decreased, but this was retrospective since they published this trial. They've been using it since 1994, and they just looked at their results. But it was hard to just isolate APRV as the cause of this and not necessarily decreasing the transfusion requirements and all the other stuff that's gone on over this time frame. Prone positioning. This improves oxygenation mostly by diminishing the ventilation perfusion mismatch, and it restores functional residual capacity. This is something that can be used in late ARDS that isn't responding to our traditional ventilation with low tidal volumes. There's been a randomized controlled study. In 2003, ICU mortality rates were decreased from 60% to 44%. They started proning patients within 48 hours of the diagnosis, and they proned them for 20 hours a day. The study was underpowered, so it wasn't really statistically significant. Other studies have shown better oxygenation with prone positioning, but there's no real good prospective trial. You can't really do a blinded trial, but there's really no good prospective trials out there. And then surfactant replacement therapy. The basis is surfactant lowers alveoli surface tension and thus increases compliance. This is in the normal lung. So in animal models, it helps that they've shown it to be a benefit. There's actually 8 prospective trials out there, all showing no improvement in oxygenation or mortality. This was up to 2004. In 2006, there was a review article that kind of looked at all this as well. They did a literature search. Their primary outcome was 30-day mortality rates. Their conclusions overall were that exogenous surfactant may improve transient oxygenation, but there was no real improvement in mortality, so they don't recommend using this as well. And then liquid ventilation is the last thing that I looked at. Lungs filled to residual capacity with perfluorocarbon. It helps by recruitment and stabilization of the surfactant deficient alveoli is the theory behind it. It also cleans the alveoli of inflammatory mediators. There's been 5 published clinical trials. Most recent randomized trial was 90 patients randomized to liquid ventilation versus conventional. They just showed less progression of the lung injury, but there was no change in mortality. They've also looked at partial liquid ventilation as well as full liquid ventilation. So in summary here, ARDS and acute lung injury are devastating syndromes. Thankfully, they are decreasing in incidence. We're seeing it less and less. They're characterized by acute onset, diffuse pulmonary infiltrates, absence of left atrial hypertension, and changed ratio. The diagnosis and therefore incidence is difficult to report. The outcomes have improved with better understanding of ventilator techniques with the low tidal volume and high rates. And most people don't actually die from respiratory failure. They die from other sources like sepsis and multi-organ failure. And the 3 general principles to treat these patients are supportive care, the pharmacological treatment, and ventilatory support. Most of this is actually the supportive care and ventilator support. So is there any questions?